Hi everyone, good evening, and thank you for joining us for tonight's update in partnership with St George Hospital. My name is Lauren Thomas and I'm CPD Program Officer at CESPN. I would firstly like to start acknowledging the traditional custodians and sovereign people on the land across which we work. I also recognise their continuing connection to land, water and community, and I pay respect to elders past, present and emerging. I'd also like to extend that respect to any Aboriginal colleagues who might be joining us tonight. Please note, we'll just have some housekeeping. So the session will be recorded and will be available on the CESPN YouTube channel within the next few days. And also at the end of the webinar, we'll have an evaluation survey, which will pop up on your screens. We'd really love if you could complete that just to give us some feedback and so we can issue your certificates of attendance. To submit a question tonight, please type your question into the Q&A box in the menu bar at the bottom. We'll also have for tonight's event, it has been accredited for 1 hour of educational activity, and we will submit that hour for you with RSCGP on your behalf. We just have some upcoming events. Please visit our website if you'd like to register for any of the following. And I would just like to introduce, so we have a few people on the line. So we have our GP facilitator, Dr. Martina Gleeson, who's one of our local GPs and is the clinical lead general practice for South Eastern Sydney Health Pathways. And she'll be assisting us tonight with the Q&A. Thank you again, Martina. And we also have Kylie Turner, who's the chronic kidney disease CNC and member of the St George Hospital Integrated Care Chronic Diseases Working Party. Thank you for joining us as well. And tonight we have Dr. Grant Pickard, who's the staff specialist in geriatrics and general medicine at St George Hospital, and he'll be presenting tonight. Thank you for joining us, Dr. Pickard.
Great. Thank you, Lauren, and thank you for the invitation to present at this meeting this afternoon. Just to confirm that my slides are visible to everyone.
I know we can't see them.
All right. Do I have to click on share again?
Yes.
Yep. There we go. How's that?
Perfect. Thank you.
Great. Okay. I have no conflicts of interests. My background, I started medical school in the UK and finished that in 1996. After working 100 hours a week in the NHS, I decided to come to Australia do something different for a year, but that was in the year 2000 and decided to stay, and then got into physician training in Australia and completed my geriatric medicine fellowship in 2008. And then walked straight into the medical assessment unit job that was a new unit that started in 2009. And that was much more general medicine focused rather than just purely geriatrics. And so then I got post-fellowship training and accreditation in general medicine. And over the years, we've developed the department. We have an inpatient general medicine unit. We do all the perioperative medicine service for the hospital, and we've developed a hospital and the home service. One of my other roles is I'm also a visiting medical officer at Calvi for rehab, so I have broad interest in patient flow throughout acute medicine, chronic diseases, and into the post-acute care world. So my talk tonight, I'll give an outline about polypharmacy, how incredibly common it is, especially in inpatient medicine, what we can do to review medications and deprescribe, and some of the tools that we can use to help support medication review and deprescribing. Lawrence asked me to present some cases. I'll start off with a case vignette, and I've got a more substantial case coming up in the presentation. So this patient, a 75-year-old male, was admitted because of dizziness on standing, and he described this as a lightheaded feeling more than a spinning feeling. He's got a variety of comorbidities, including dyslipidemia, hypertension, type 2 diabetes, atrial fibrillation, and heart failure with a reduced ejection fraction. And as per the guidelines for all these chronic diseases, he's on a whole list of medications. So, rosuvastatin, the Entresto, sacubitril valsartan combination, metformin, frusemide, spironolactone, apixaban, nebivolol, esomeprazole, and Movicol. And already, I'm sure that you're starting to think about, potential problems and interactions with this medication list. We measured his blood pressure, 115 over 75 lying, and then a postural drop to 88 over 62 after 2 minutes in the standing position. Heart rate 65 per minute and irregular. We've also got some blood tests to come back as well. So potassium's high, and he's got an acute kidney injury. His renal function was previously normal, now creatinine 166, eGFR 24. What would you do with this patient?
I'll get people to put answers in the Q&A, and I'll keep my eye on it for people.
Yeah.
Can you just go back to the list of medications?
Sure, yep. Okay. So look, just for ease of simplicity, we've got issue of hyperkalemia. So we've got valsartan and spironolactone that make your potassium go up, and frusemide that makes it go down. Currently, the potassium's high, so we have to address those two medications.
Somebody else has also added stop metformin.
Yeah, I've got an acute kidney injury, so let's look at the nephrotoxic medications in there. So valsartan, metformin, frusemide, spironolactone. We've got to be careful.
Somebody else has suggested adding Jardiance.
Yeah, that's a good thought.
Instead of metformin.
And apixaban,
yeah.
you're getting to that level of impaired creatinine clearance where we have to start thinking about either dose reducing or thinking about whether this medication is appropriate to continue if we can't get any resolution of this patient's problems.
Somebody else has said stop Lasix.
Yeah. Okay. So yes, we've got to. Well, certainly the priority is get the potassium sorted out, get the acute kidney injury sorted out, get the postural blood pressure stabilized as well. So when we talk about polypharmacy, let's be aware that many patients do benefit from appropriate use of multiple medications. Certainly there's growing complexity and comorbidities of the patients that we see, certainly in acute inpatient hospital care. But we also have to be aware that inappropriate medications do contribute to problems. And as much as we prescribe, we also need to consider deprescribing. And that's the act of systematically identifying and tapering, reducing, or stopping medications that are no longer indicated or causing problems or the potential to cause adverse effects. And ultimately, what we're trying to do is ameliorate or prevent drug-related harm. And I've referenced my friend and colleague Ian Scott, who's a general physician and epidemiologist in Queensland, who's really, led the way in a lot of the research and papers on this topic. So let's talk about what polypharmacy means, its prevalence and its outcomes. So polypharmacy is very simply defined as 5 or more medications. It sounds a lot, but it's very, very easy and very common to get 5 medications. And 2/3 of the over 75s that we see in hospital are on 5 or more medications. Hyperpolypharmacy sounds really bad, but it's 10 or more medications. It sounds huge, but it's not that uncommon in the multimorbid patient. And although these definitions are numerical, the emphasis is always on about evidence-based practice and the goal of reducing inappropriate polypharmacy. A lot of these medications may become long-term use, and like any medication, the initial indication may get lost in time, and the medication is just continued for uncertainty reasons. We have to be aware that as we age, that aging and frailty may mean difference in how medications are processed. So absorption, distribution, metabolism, and excretion are all changed as we become older, and different body compositions of sarcopenia and body fat ratio distributions. And there's often interactions with diseases and age-related syndromes. So delirium, malnutrition, incontinence, falls all become part and interrelated. As polypharmacy increases, there's also increased complexity, such as surgery for fractures from falls and poorer health outcomes. And this leads on to the question of, does each medication, does the risk outweigh the benefit? It's certainly a big problem in our healthcare system. 1 in 4 older patients in the community are hospitalised for a medication-related problem over a 5-year period. Up to 30% of admissions for patients over 75 years old are drug-related, and that's certainly consistent with what I see in acute inpatient general medicine. 3/4 of these are potentially preventable. A third of unplanned readmissions in older patients are drug-related, and potentially inappropriate medications make up a large proportion of residential aged care facility residents and community residents. And in both primary care and hospital practice, 1 in 5 prescriptions issued for older adults is inappropriate. Why are we doing this in the first place? So as general practitioners, you'll see the community-based patients, and fortunately, you're a little bit better off than what we see in acute general medicine inpatients and acute geriatrics inpatients. Hopefully, by the time the patients have progressed on, the most frail patients in residential care facilities, we're trying to reduce inappropriate medications for these patients. Some of the risks of polypharmacy in older patients, inappropriate prescribing. So, some drug-drug interactions, drug-disease interactions, drug and food and nutrition related, and that interaction with geriatric syndromes. And often there's a prescribing cascade. A patient will come into hospital with pain. They get some paracetamol to start with. There's still doesn't quite solve the pain, so we give them a little bit of endone. The person who writes the endone prescription also writes the laxative prescription, trying to manage that. And as when anyone comes into hospital, they get given some DVT prophylaxis, so they're often given enoxaparin as well. There's often 4 new medications just from coming through the door of a hospital, in addition to anything else that they may be taking previously. Clinical risks, obviously adverse drug reactions, more common as more you take. The potential for geriatric syndromes, hospitalisation and healthcare utilisation rates go up, institutionalisation, and unfortunately death. And this has an impact on patients and carers in terms of administration times and costs as well. But it's not just the numbers of medications that people take, but also the type and the dose of medications that also determines the risk. The number of medications prescribed is strongly correlated with the absolute risk of harm and potentially inappropriate medications. So one of the work that's come out of the sort of polypharmacy and deprescribing academic workup is the drug burden index. It's a pharmacological measure of an older person's total exposure to medications that have an anticholinergic and sedative effects that impair their physical and cognitive function. And really, the main classes that we look at for this will be antipsychotic medications, the benzodiazepines and other sleep medications, opiates, and the neuropathic analgesia medications of gabapentin and pregabalin, antidepressants, antimuscarinics, antihistamines. And these are all very commonly prescribed medications. And a higher drug burden index is associated with adverse outcomes in older adults. So impaired physical function, falls, frailty, hospitalization and GP visits, institutionalization and mortality. So I'll move on now to the feature case presentation. I'll go into more depth and detail with this presentation. So, a patient I've seen, a 93-year-old female who recently moved from Orange to Sydney and was admitted under my care on the 27th of January. So, 27th of January was a day in lieu for Australia Day falling on a weekend, so it was a public holiday. Her presenting problem, acute on chronic thoracic back pain. And we'd got some information that she'd got a background of some previous thoracic vertebral fractures. And there was also associated symptoms of decreased oral intake, nausea, and intermittent vomiting. Unfortunately, because of, I'll go into the full details of her medications, but again, the problems of admitting someone on a public holiday meant we didn't always have the full information on first arrival. But we've got further background information of ischemic heart disease with a previous non-ST elevation myocardial infarction, aortic stenosis but with preserved ejection fraction, chronic kidney disease, stage 3B, osteoporosis with known previous thoracic vertebral fractures, a previous fall with a traumatic subdural hemorrhage, and that was whilst on an antiplatelet agent, osteoarthritis and glaucoma. So a range of age-related diseases that have accumulated over the years. She was currently living alone in a first floor unit with lift access and no steps, was independent with her activities of daily living and instrumental activities of daily living, and used a walking stick. She got some help from her niece for shopping and transports, had some cleaning services at home. She was a retired travel agent, never smoked, and did drink one standard drink per day. The examination on arrival, GCS 15, sugars normal, but she was distressed and appeared in pain. The systemic examination showed her aortic stenosis murmur, but no evidence of heart failure. Respiratory and abdominal examinations were unremarkable, but she was very tender over her mid to lower thoracic back. In the emergency department, a CT spine was performed, and there were some evidence of thoracic vertebral fractures, as highlighted by the arrow, so the loss of vertebral heights at a couple of levels. So I got to see her the next day. We're all back at work after the public holiday weekend, and her back pain was improving. She then shows us two separate Webster packs, and we look at these and we go, oh my gosh, they're from different GPs and different pharmacies. Which one have you been taking? She wasn't entirely sure because she was taking bits from this and bits from that. We found out that, you know, she'd self-administered multiple Panadine forts prior to admission because she was in pain, and there was also some Targin, slow-release opiate analgesia in her Webster pack. And, you know, we just weren't sure from the Webster pack that it was being taken appropriately either. So, you know, there's a lot of medications that we're just not sure whether she's taken them at the right time, what's been, you know, what was taken on what day. But here's a big long list: atorvastatin, frusemide, metoprolol, magnesium. We saw that Norspan was on her list, you know, because it's not a tablet medication, it wasn't in the Webster pack, but we couldn't find any patches applied to her skin, and she did say that she'd stopped that herself a week, stopped that prior to this presentation. Perindopril, Residronate, Targin at a pretty substantial dose, Panadine fort, although it says ceased, you know, the patient did report that she was taking this for pain management. Endo, we weren't sure how many she was taking, and temazepam as well. I'm sure that you look at that list and go, oh my gosh, you know, there's way too many, you know, risk medications there. We did some bloods, and her liver was really in quite a bad way. There was an acute transaminitis. That ALT and AST were both markedly raised, but fortunately the bilirubin, GGT, and ALT were all normal. There was evidence of an acute kidney injury. Creatinine peaked at 195, but fortunately it came down to 140. So, you know, we've got an acute liver injury that we suspected was secondary to a drug-induced liver injury. We just weren't entirely sure how much paracetamol as part of the Panadine fort that she'd been taking. A level was 16. We erred on the side of caution and did give her some N-acetylcysteine to cover for this, just given how severe the LFT rise was. We were also aware that she hadn't been eating well, and there was a risk of the glutathione, the metabolite to help manage potassium metabolism. Or was this just an idiosyncratic drug reaction? Who knows what she'd been taking from her combination of 2 Webster packs. We did the rest of the liver workup. It was reasonably unremarkable, and as I said, we did give her some N-acetylcysteine, and fortunately, the LFTs did completely normalize by 3 weeks later. We went to town on her medications and put a line through quite a lot. So Residronate was stopped due to acute kidney injury. We stopped the Targin and tried to rationalize her opiate analgesia. Fortunately, she'd self-ceased the pretty substantial dose of Norspan patch. Atorvastatin was stopped at the time of the acute liver injury. Paracetamol stopped. Perindopril from the renal impairments. We managed to get her off the temazepam as well. So, as I say, we changed multiple opiates to a single opiate. She's obviously got fracture and pain, and we tried to manage that in a more streamlined and thoughtful approach. Her timeline, obviously when she came in, we dealt with the polypharmacy, the acute liver injury, the acute kidney injury, and optimizing her pain. We moved her across to St George Private, but then she came back with new AF and anemia. A couple of weeks later, she'd become deconditioned, and we organised some rehab and was eventually discharged in late February. But when anyone's had one fracture, there's always a risk of further fractures, and unfortunately she'd had a fall and a fractured neck of femur, required an intramedullary nail insertion, and further complications of hospital-acquired pneumonia and urinary tract infection. So she eventually got back to Calvary for some reconditioning and post-operative rehab. During that admission, we had the time then to really work on her pain management. Initially, it was quite poor on admission and limiting her exercise, so we did have to increase her opiate analgesia again. We checked with the bone scan, and that fortunately excluded any other new and acute fractures, just the ones that we knew about. Over time, there was slow and steady progress with her gym exercises, and we were able to wean down her Targin as her strength improved and her gym performance improved. How do we know that her function improved? Well, we've got some rehab parameters. So bed mobility started off at moderate assist of 1 person and ended up as independent. Sit to stand, again, from 1 assist to independence. Mobility, 1 assist with a forearm support frame, and eventually at discharge, she was independent with a 4-wheel walker. 2-minute walk test went from 10 meters to 55 meters with a 4-wheel walker, and her Tenetia balance scale went from 14 out of 28 to 24 out of 28. So in summary, we managed to get her home with just a small dose, 5/25 5/2.5 milligrams of Targin, and her liver tests and renal function were both much improved by the time of discharge. Are there any questions or comments that anyone would have about the case?
Grant, can I ask a question while I
course, yeah.
encourage the other participants to post questions in the Q&A? She came in with 2 Webster packs from 2 different pharmacies and 2 different GPs. Did you address that? Because that's a really big discharge planning issue, and it often
absolutely.
isn't addressed.
We were, we were very clear with her, just saying that she was lucky to survive her medication misadventures. I didn't sugarcoat it in any way. It was, that. Yes, we wanted her to feel comfortable, but you can't just go. You've got to have in my opinion, a single prescriber and a single pharmacy to deal with this.
Absolutely, with opiates, I agree.
Yeah, and to see even the big dose, a Norspan 20 and Targin 15 are doses that I find uncomfortable with.
They'd make me sweat.
Yeah.
But so with a discharge summary, did it go to both of the GPs that were on the Webster packs?
I think by that stage we'd had the benefit of time to sit down with the patient and her niece and say, look, who's the one person that you're going to follow up with, and she did specifically name one follow-up GP. So
and hopefully one
fingers crossed that we've stopped us shopping around.
Yeah, it's hard to know why she had two GPs, and it may just have been that she was looking for more pain relief. And yeah, we don't tend to suspect our 93-year-olds of being Dr. Shoppies.
It happens.
Little old lady wouldn't do that. So I'm not seeing any other questions.
Okay,
I have got one more question though. Do you think the cause of the sudden onset of the lower thoracic pain was because of the osteoporotic fractures that were old, or do you think it was referred pain from the liver?
I think she had new fractures.
They just didn't show on the bone scan.
Yeah, obviously CT will just show you a decrease in vertebral height, but when we eventually got round to a bone scan, because of slow progress at rehab, that it just showed the expected healing of a fracture at that time on the bone scan.
Right, that wasn't clear. I thought you said they were old fractures, but yeah, that makes more sense.
Well, she said she'd had some old fractures. As you say, CT is a good modality for just showing a fracture, but it doesn't always tell you acuity.
It's a good reminder that paracetamol toxicity is a very real risk in elderly patients.
And thank goodness we've decreased our box size of paracetamol.
Yeah.
Okay.
I don't see any more questions. Sorry.
All right, I'll move on. Okay, so next part of the talk about how we review medications and deprescribe. Some of the barriers, though, why wouldn't we do this if I'm trying to make the case that it's all beneficial? Well, often awareness. We're not aware that a medication's inappropriate until that may be pointed out. As I said, the initial indication may have just been years ago, and we're not sure why that medication's there, and we just go, oh, okay, well we'll carry on. Inertia, that same feeling that it may be inappropriate, but we don't know any better to make any changes. We may not feel confident ourselves to know how to make the change, and there may be other feasibility or extrinsic factors on the prescriber. But I've got a pathway, that how you're trying to approach this. If there's no benefit. So the first case I presented, obviously significant toxicity, of hyperkalemia and acute kidney injury came into play. So, we had to make some medication changes and make them quickly. You then, like every medication that you prescribe, you try and address whether benefit outweighs harm or harm outweighs benefit, and what are the symptoms or disease that may change when you make a medication change. So I see patients in acute inpatient medicine. It's often a very good time to review the list. It's often someone different than who's originally prescribed the medications. I say a third of the admissions that come into my unit are inappropriate medications or consequences of medications. And we're dealing with adverse drug reactions. We're dealing with the consequence that may have on a frail older person, falls, delirium, and to their patient function and quality of life. It may be directly relevant to their change in condition. And, I'm supported by very good hospital pharmacists who, go to, incredible efforts to try and give me an accurate medication list within the first 24 hours of that patient being in hospital. I've also got the backup of a multidisciplinary team as required. And it's part of hospital accreditation standards these days. But some of the barriers, obviously we've spoken about the lack of appreciation of hazards of polypharmacy, clinical inertia. We may just be putting all our efforts into dealing with the acute illness, and it may just slip our attention that they've got a long list of other medications. It may take time to gather the necessary, correct and accurate information. Patients themselves may not have health literacy or health awareness for why they're taking those medications. But certainly reducing inappropriate polypharmacy is a priority for my college, the Royal Australasian College of Physicians. A few years ago, the college did come up with a program called Evolve, which is about trying to reduce low value or inappropriate practices and interventions. And I'll go through some of the specialist society sort of recommendations that came out of Evolve. Every specialist society was asked to come up with the top 5 low value practices that we could recommend that we try to avoid. Certainly the Internal Medicine Society, our specialist society for general medicine, said avoid medication relation harm in older patients receiving 5 or more regularly used medications by performing a complete medication review and deprescribing where appropriate. The Palliative Care Society said to avoid medication interactions in case of polypharmacy, don't prescribe unless conducting a drug regime review. I think this is fairly good, just prescribing information for anyone. Gastro Society, don't prescribe proton pump inhibitors long term without attempting to reduce the medication or stopping altogether. Geriatric Medicine Society came, 4 of their 5 recommendations were medication related. So don't use antipsychotics as first line to treat behavioral and psychological symptoms of dementia. Don't prescribe benzodiazepines or other sedative hypnotics as a first choice for insomnia, agitation, or delirium. Don't use antimicrobials to treat asymptomatic bacteriurias, and don't prescribe without conducting a medication review. The Society of Clinical and Experimental Pharmacologists and Toxicologists, well, they're the Pharmacology Society, stop and recognize and stop the prescribing cascade. Reduce the use of medicines where there's a more safe alternative non-pharmacological management strategy. Avoid using higher or lower dose than is necessary. Stop medications where no further benefit will be achieved or the potential harm outweighs the potential benefits. And reduce the use of multiple concurrent therapeutics, the hyperpolypharmacy. So I've got another case. This patient's a current inpatient of mine, Mr. AL, 65-year-old male. He had a fall and he presented with some left arm pain. He's known to have end-stage kidney disease. I've said from diabetic nephropathy, but he's really from a variety of other kidney problems as well. He's had a nephrectomy due to renal cell cancer, and he's also had a bladder transitional cell cancer and type 2 diabetes. He's on hemodialysis 3 times a week in center dialysis. And actually his fistula's on his left arm, the arm where the pain is. Other background: hypothyroidism, hypertension, osteoarthritis, and he's also got a fairly new diagnosis this year of vascular Parkinsonism, obviously a neurological problem that puts him more at risk of having a fall. But at present, he's at home with his family and requiring a gait aid to help mobilize. He comes in on a huge list of medications: allopurinol, candacetin, cinacalcet. This is a calcimimetic medication for reducing parathyroid and phosphates in patients with chronic kidney disease. Colchicine, darbepoetin, the erythropoietin for renal-related anemia. Licofalin, which is a medication for pruritus with chronic kidney disease. Duodart, gliclazide, thyroxine, linagliptin, metoprolol, paracetamol, pregabalin, and rabeprazole. Huge long list of medications there. Anyone wish to have a comment on his imaging?
We can see a fractured neck of humerus.
Yeah, he's got a fractured left neck of humerus, and the concern is that that's in the arm that where his dialysis fistula is at as well. So obviously it's going to make dialysis tricky. You want to, obviously try and keep that arm as comfortable and still as possible. But his first few episodes of dialysis whilst he had managing this fracture were requiring some extra analgesia.
And he's also got some asymmetry in his brain CT.
Yeah, so this you know, I've obviously just shown you one slice from his CT brain, but this is a really markedly abnormal CT brain for a 65-year-old. The ventricles are much bigger than expected. There's much more CSF than expected, so there's significant atrophy. If you look around the grey-white matter changes around the ventricles, you can see significant small vessel ischemic change within this brain as well. Fortunately, there's no obvious macrovascular strokes. There's no bleeding as a consequence of the fall. Okay, so we go back to his medication list. Candesartan, his potassium was high as part of his blood workup, and as much as we've tried to manage that at dialysis, we've also stopped the candesartan. Other medications that we've been trying to make sure his blood pressure's under control. He does run a little bit hypertensive, so we've still left him on the metoprolol, and we're trying to manage his fluid status at dialysis. And the pregabalin as a falls risk medication. We're just trying to get some information from his previous neurologist why he may be on this medication. Another case vignette. This is a patient I see in the outpatient clinic. So Mrs. JJ, 69-year-old female, and I see her in the geriatrics clinic for some cognitive problems. And we've noted that she's got a MMSE of 23 out of 30. Again, maybe a little bit lower than you'd expect for anyone at age 69. And the combination of Alzheimer's and vascular disease noted on, well, certainly vascular disease noted on her imaging, but vascular disease profile on her cognitive tests. She is seeing a psychologist for, a psychiatrist for bipolar disorder, and a lot of her medications are psych medications. So the epilim has been used for mood stabilization, and quetiapine at a dose that I just can't imagine ever giving someone that much quetiapine. I give 25 or 50 milligrams to start off with. I'm very uncomfortable. We're seeing 1,000 milligrams daily of quetiapine. Actonel for her osteoporosis, simvastatin for lipids, sertraline again, just trying to help manage her anxiety, depression, thyroxine, paracetamol, and Lipitor. I've had fairly long conversations with this patient and her husband, and with the psychiatrist about these medications and the impact that they're having on her, not only on her cognition, but a pretty slow gait that she has. And we've kind of just reached a equilibrium at the moment. Fortunately, her cognitive testing over time hasn't significantly changed, but nor have I been able to make any inroads into trying to cut down any of these medications. I think the psychiatrist has tried with, dose adjustments, and it's led to an exacerbation of her mental health problems. So yes, we're kind of just at a plateau and an equilibrium stage at the moment. I'll move on now to some deprescribing guidelines. Probably the one that's most commonly known worldwide is Beers criteria. It's not Beers the drink, but Dr. Beers, the geriatrician who first described them. Got some slides coming up about those. The CEASE framework's an Australian technique that we can use. STOP-START is an acronym for Screening Tool of Older People's Prescriptions and Screening Tool to Alert Right Treatment. And I've also got some slides coming up about deprescribing protocols. So I've spoken about the Beers criteria. Unfortunately, Dr. Beers has now died, but his name lives on as sort of as the author for the original version of these criteria. But they are revised every few years. This is the most up to date version. And it's really all about, you know, trying to recognize inappropriate medications, and especially where harm may outweigh benefit for these medications. There's a reference at the bottom of the slide if you want to look these up. The ones that I look at it is if a patient comes in with delirium. Obviously, there's a whole long list of medical conditions that can cause delirium, but in general, you're looking at infections and medications, so bugs and drugs. And if it's not bugs, then pay particular attention to the medication list. And anticholinergics, antipsychotics, benzodiazepines, corticosteroids, often a significant contributor to patients' delirium, and certainly opiates are the big one that we have to be very careful with. And anyone who comes in with a fall, well, it's pretty much a similar list. So anyone who has a fall, when I review the medication list, I'm looking at, are they on any medication that affects or works on the central nervous system, anything that affects the cardiovascular system as well. The CEASE framework, it's an acronym. So this was applied for general medicine in patients age 65 or over taking 8 medications. C, current medications are ascertained. E, evaluate risk and potential for harm. A, assess each medication benefit versus harm. And obviously you're looking at the higher risk medications where possible so it's S sort, and you try and prioritize the higher risk medications. And E, eliminates, implement and monitor discontinuation. And when this framework was applied, the 84% of patients had at least 2 medications stopped. So it's quite a useful technique. In New South Wales, we've got the Therapeutic Advisory Guidelines Quality Use of Medication Indicators. And these provide some guidance for hospital drug and therapeutic committees on management of inappropriate polypharmacy in elderly hospitalised patients. Here's a patient I was looking after last month, a 78-year-old female, a case vignette. So brought in by ambulance from home. She'd had a fall just at standing height, and she'd been having a lot of falls, 5 falls in the week prior to admission, and reduced mobility. And her falls frequency had increased, and she was standing looking at books and felt that her legs had given way and her body had become weak. She'd fallen backwards and was on the ground for about 45 minutes, and before the family couldn't get her up and called the ambulance. I think 45 minutes is quite a long time for anyone to be on the floor, especially a hard floor. This patient's got a very significant falls risk from her musculoskeletal comorbidities. So she's had a lot of previous spinal surgeries, osteoarthritis of the knees managed with knee replacements, and unfortunately the right knee replacement had been revised, and she was had a chronic infection of this medication, and she was on long-term antibiotic suppression management for this. She's had also not only surgery of her knees, but also in her feet and toes, and a variety of other surgeries along the years. So when she comes in, we ask for a medication list, and here's the list that the GP was able to supply. I'll invite any comments about that anyone has about this medication list.
Please start typing.
What catches your attention? What are some of the drugs that you think are high risk?
I can see 2 antibiotics.
Where's the problems? Yes, yeah. So we I think was it? I think it was. I don't know whether it's ciprofloxacin or something that.
She's got Cefalexin.
Yeah, the Bactrim was for her knee chronic infection suppression.
Oh, of course. Okay. Yep. So someone's written Duragesic patches, gabapentin, Lyrica, and Targin.
Oh my goodness! Yep, that would make a horse fall over.
Doubling up, wouldn't it?
Yeah. And again, pretty substantial doses. Targin at 20 milligrams twice a day.
then add Valium, and then
yeah.
add to the risk you're on Pradaxa. So if you fall, you're going to bleed.
Yeah, so all right, so the
Lovely.
stakes are higher. So we're on anticoagulation. Falls and anticoagulation is not a good combination. Okay, what do we do? How do we approach this
Someone
list?
else has commented that Livial has no benefit in this woman, but
Yep. So we got some further information. This patient's seeing a chronic pain specialist, and so, as much as we look at the fact that there's fentanyl patch and Targin, and you go, why would anyone be on 2 slow-release opiate medications? I didn't, I obviously, got to respect my specialist colleagues prescribe these medications, but I'm now dealing with a patient who's having multiple falls a week. What do I look at? I'm going to put my efforts into the benzos, the temazepam and the Valium. I don't think she said she wasn't taking too much of the diazepam. So I started a conversation about how we can help to try and reduce her falls risk by looking at trying to wean and reduce her temazepam. And it was met with fairly open hostility from the patient, unfortunately. I'm trying to explain that this medication, doesn't really have any great benefit for the patients, but she felt it was absolutely necessary and that she couldn't sleep without it. My explanation is that anything that sedates the brain puts you at risk of falls. So we did eventually try after a few days of not making much progress with exercise, try to work on trying to put in place a weaning regime for the temazepam. So what's some of the techniques that we can use for helping deprescribe these temazepam? So we've got some local New South Wales guidelines for deprescribing tools, and they're really easy to use, these ones. I absolutely love referencing them, and it's something that just very easy to share with patients as well. So we've talked about trying to deprescribe the benzodiazepines, and including that's the Z drugs, the Zopiclone, the Zolpidem. Unfortunately, I'm not seeing too many of any patients on these medications anymore. Hopefully, the word's got out that they're I think the toxicities outweigh the benefits for the Z drugs. So I'm not seeing too many of these being prescribed at the moment. But certainly the benzos that are prescribed for insomnia for patients in their sort of 40s, 50s, and 60s get continued, and then I'm seeing them as they're falling in their 70s and 80s and 90s, and you've got to then address these long-term medications that people have been on and feel that that their life will fall apart if they can't sleep and don't have these medications. But we have to explain that the risk does outweigh the benefit. So we've at least got a structure that we can use with these deprescribing guidelines for identifying the inappropriate use. There are some times when benzos are useful for acute alcohol withdrawal, or where there's a treating psychologist feels that it's necessary for their severe anxiety or grief. We consider the adverse effects and whether the medication is likely to cause more harm than benefit. These guidelines also great because they come with a template for how to set out your explanation to the patient, and further points are that you then a very slow weaning of these medications. So as much as the general principle of prescribing for an older person is start low and go slow, it's the same in reverse. When you're deprescribing, you make slow changes and monitor for response. And there's a printout leaflet that you can give to the patients to explain, what the rationale is for what you're doing and what are some of the symptoms that they may encounter. So once again, I've showed this slide before, but I'll put it in at this stage as we're coming to the end of reviewing and having a framework for reviewing a medication, trying to define benefit and harm for each medication, and what may be the outcome of what happens when you do change or stop any medication. So what we're looking for are the consequences of deprescribing. There may be no obvious change in clinical status, but you've stopped the patients and the community and the taxpayer funding the cost of a non-essential medication. Just as an aside, that medications are inappropriate medications are a significant contributor to carbon footprint of healthcare, and we may have, by taking them off a medication now, we may have reduced future problems. There may be resolution of specific adverse drug reactions. Just in the main case that I presented this evening, there was significant adverse drug problems. We may see an improvement in function and quality of life. Certainly after taking some patients off benzos, that I've seen improved cognitive function and reduced falls. We may see withdrawal syndromes. So as I've said about benzones, of confusion, hallucination, seizures. So again, be very careful. Don't stop them suddenly. They need to be weaned carefully. There may be rebound syndrome. So if you stop someone's beta blocker suddenly, they may get a rebound tachycardia. And there may be a reappearance of the symptoms of the original disease that medication was being used to treat. So if you take someone's prednisone down, they may get a reactivation of whatever inflammatory disease that they may have. There's some further online education modules for hospital clinicians. I find the HETI My Health Learning course is quite helpful, so that's available as a resource. So my final slide about take-home messages. Deprescribing is an essential part of good prescribing. With every medication, we try and evaluate the risk. Does it outweigh the benefit? And if it does, then we consider the overall drug load, the comorbidities, the functions, and the specific goals of care for that patient. When you're writing a new prescription tomorrow, when you're starting a new medication, give consideration as to what criteria would warrant its future discontinuation. I don't think any medication should really be set and continue forever. And deprescribing is integral to end-of-life care and advanced care planning in patients with multi-level advanced chronic diseases. Thank you.
Thank you so much. I have a few questions related to the presentation. Just going back to your lady, the last lady that had the very high doses of narcotics as well as pregabalin and gabapentin and the temazepam and the diazepam. Is it like one of the things you said is I have to respect my pain colleague, and I think that is one of the things that makes it harder for us to deprescribe it, because we feel really we have to respect our specialist colleague, even though we're specialists ourselves. But is it worth having a conversation with the pain specialist and saying, can you review this while the patient's in hospital?
Yeah,
because
absolutely. So I think open communication in these situations. The classic one I encounter is with the cardiologists, and I've got a patient with no blood pressure in the standing position, so I'm trying to de-escalate some of the blood pressure medications, and the cardiologist will call me and say, these are evidence-based medications that you must use them to help prevent progression of heart failure. I go, but this morning I was picking them up off the floor because they have no blood pressure.
Yeah, if they break their hip and die, then they're not going to need.
So it is challenging when chronic disease management, that the evidence-based chronic disease management is why we use these medications in the first place. But if they then cause problems, then often acute problems outweigh chronic benefit.
And that was my next question, related to things that probably don't have too many adverse effects, although they will do a bit. We have people on, fairly large doses of statins and ACE inhibitors because we're trying to prevent vascular disease. But when does the benefit stop outweighing the risk? 80, 85, 75?
There's no magic number, so prognostication is incredibly difficult. But if you look at the patient, one thing that's been reasonably well validated. It's called the surprise question. You have a patient in front of you, you're aware of their age, their comorbidities, their medications, their mobility, their home situation, and you ask the question, would you be surprised if this patient were to die in the next 6 to 12 months? And however you answer, you're probably right. And if you answer you wouldn't be surprised, then you really do need to start the conversation moving towards what's important for that patient. The multi chronic incurable comorbidities are maybe now progressing to a level where symptom burden becomes more intolerable than trying to
prevent
further complications of the disease. So it's obviously very individual. Clinical medicine is involved with this in these situations.
There's two really important questions here. One is if we need assistance with developing a deprescribing plan, can we refer patients just for that? Like
Absolutely, yep. So certainly
the
that at St George, our clinics for geriatric medicine are general clinics. We don't do specific dementia or falls clinics. They're just general clinics, and part of a comprehensive geriatrics assessment is a full medication review.
Yeah, I agree. And I think we can also use a pharmacy medication management review, but often that's a bit cut and paste. It really depends on the clinical acumen of the pharmacist.
Pharmacists I work with are brilliant, but they'll tell you every interaction because they've put them into their drug databases.
Their drug database search, yeah.
But it's then our role as the doctor for that patient to go, well, what does it mean for this patient, and how do I apply it for this individual? Yeah.
Somebody else has asked, is it possible while in hospital and they're in bed, they can have a worse drop in their blood pressure than in community?
Yeah, look, so obviously, often patients come in with non-specific presentations, and you're trying to work out what's going on. We may measure a postural drop, but what's causing it? Is it have they got sepsis that's just not showing in particularly any other ways that's hard to find? Are they volume depletes, intravascularly dry? Do they have a disease of the autonomic system that's just not been picked up in any other way? Often some of the diabetics and alcoholics that we have, that their autonomic system's completely shot, unfortunately, and that they just have great difficulty maintaining a standing blood pressure. And you'll take them off all their blood pressure medications. You'll give them some fluids, and often they're then onto the mineralocorticoid medications such as fludrocortisone and midodrine to try and help get a satisfactory standing blood pressure.
Sometimes we see that when patients are in hospital and they've got big sick, that their blood pressure goes low because they're sick, and then they recover and they come home and they recuperate, and then their blood pressure starts going up again because they're not big sick anymore. And
we'll get them on the ward after a week in ICU, and they've become deconditioned. They've reset their baroreceptor responses. Yes, ICU's stabilize them, so to speak, in the supine position, but we're trying to get them upright and mobile
get
again.
Them up.
Yeah,
exactly. I think they're the main questions. There was one question, your lady with the fracture and the transaminitis also had an elevated ALP, and someone wanted to know if that was related to her fracture or if it was just related to the transaminitis and the paracetamol.
It was because it settled down. We put it all down to
the paracetamol.
The paracetamol, yep, and the medication. So.
There's a new question that says, is it acceptable to be on a single low-dose benzo or Z-Med long-term?
Depends what the indication was for in the first place.
Yeah, and what the adverse effects are.
If it's to help someone get over alcohol withdrawal, yes, there's a role for these medications, but that's not a long-term role.
I think that's the end of our questions. So Thank you very much for your presentation.
Thank you to Lauren for organising, and thank you, Martina, for being such a good facilitator.
Thank you. Just want to let the participants know that there is a health pathway for medications and polypharmacy on the southeastern Sydney site, and it's in the process of being reviewed and will be updated soon, and we'll also be launching a live deprescribing pathway. But Sydney Health Pathways, which most of our users have access to as well, has a current deprescribing pathway, and when our deprescribing pathway goes live, theirs will be the same as ours because they'll be following. So keep an eye out for them if you're going through this process with your patient, because it's got links to all of the really helpful resources that Dr. Pickard posted in his slides. So to reinforce the learning, but that's really interesting. I find it one of the biggest challenges. I would have to admit to being guilty to having some patients with 10 medications or more, and you look at them and go, oh, what can I take away?
It is very hard to try and change something that's been already set, and but people change with age, and we've got to review.
Yes, I think we need to be thinking it all the time.